All right, it is 12:30, so we will begin. Welcome everybody to the Brown School's Open Classroom program. Open Classroom is our free webinar series. We also have a ton of different professional development opportunities that can provide continuing education units and deeper learning. If you are interested in checking those out, we invite you to visit the link on your screen. There's a QR code that you can use as well, and I will drop that into the chat. That link is brownschool.wustl.edu/professional-developments. Just a couple of housekeeping items before we officially get started and introduce our presenter and program today. This is a Zoom webinar, which, as you can see, just means that we can't see or hear you, but we have enabled the chat, and we do hope that you will use it, especially to ask any questions that you have. We will have time for Q&A at the end, and we'll get to as many of those as we can. So if you do have a question, feel free at any time during the presentation to drop that into the chat. Finally, this program is being recorded, and the recording will be shared on our Open Classroom website, which you can see on the screen here, and I will also drop into the chat. That's brownschool.wustl.edu/open-classroom. The recording should be up probably tomorrow or the following day. All right, well, at this point, I will pass it over to my colleague, Sarah Lucan, who's the Associate Director of Admissions and Recruitment for the Brown School. She's going to introduce our speaker and program for today. Sarah.
Great, thank you, Sarah. And welcome, everyone. Thank you for joining us today. I want to give a special welcome to prospective Brown School students. We are very glad you're here. I'm thrilled to welcome you to the second installment of our Curriculum Showcase series on Open Classroom. I'd like to thank Sarah and the Brown School Professional Development team for partnering with admissions to bring this great series to our prospective students and the community. What we hope that you gain from this Open Classroom is a little more knowledge about the topic being discussed, and for prospective students, a sense of what you can expect in the classroom with the renowned faculty members who are being featured in the series. Today's session specifically offers a sample of the types of issues addressed by our public health related curriculum, particularly the mental and behavioral health concentration in the Master of Public Health program. I am pleased to introduce today's speaker, Alexis Duncan, MPH, PhD, who is an associate professor of public health at the Brown School at Washington University in St. Louis, where she conducts research on the epidemiology of substance use disorders, disordered eating, and psychiatric comorbidity. She is currently investigating differences in factors related to substance use and eating disorders at the intersection of race, ethnicity, and gender, and other socio-demographic characteristics, highlighting the need for data disaggregation for identification of causal mechanisms and development of interventions. Dr. Duncan is passionate about the training of future public mental health and social work practitioners. She serves as the chairperson for the Brown School's Master of Public Health concentration in mental and behavioral health, and is co-director of a substance abuse and mental health administration grant to expand the MSW program's curriculum on substance use disorders. Dr. Duncan received her MPH and PhD degrees in public health with a concentration in epidemiology from St. Louis University. Prior to her faculty appointment, she completed a postdoctoral fellowship in psychiatric epidemiology and behavior genetics at the Washington University Department of Psychiatry. And without further ado, I will give it over to Alexis.
Thank you, Sarah, and thank you everyone for joining us this afternoon. I'm going to share my screen. So, as Sarah said, I am having problems. That's not what she said, but there we go. Okay. So I am the chairperson for the mental and behavioral health concentration, and I teach a course called Public Mental Health. And so this lecture brings together pieces of a lot of different lectures in that class. And so in the class, we go into much greater depth on all of these topics with regard to substance use disorders and other mental health issues. Okay. Oh, and I should mention the course is a dual listed, so both for MPH and MSW students, because I saw some of you are prospective MSW students. So today I'm talking about substance use disorders through the lens of public health. So what does that mean? Compared to, for example, a clinical perspective and taking a public health perspective, among other things, we take a population level rather than an individual level view. And we focus on prevention. And as you can see from the figure on the right, which shows the 10 essential public health services, we center health equity. Now, the first thing we need to talk about in epidemiology, we talk about case definitions. So when we want to assess a health condition in the population, we start there with the case definition. So what are substance use disorders? Substance use disorders, unlike other mental health diagnoses, are conditioned on using substances. And by a substance, we're referring to the non-medical use of drugs such as alcohol, cannabis, and opioids, and those drugs directly activate brain reward systems. When used to excess for an extended period of time, some, but not all people will develop a substance use disorder. Substance use disorders are characterized by continued use of a substance despite significant problems that are caused by or exacerbated by use of the substance. Under DSM-5, which is our current diagnostic system, that's the Diagnostic and Statistical Manual of Mental Disorders, there are 11 symptoms of substance use disorder, which can be broadly categorized into symptoms regarding impaired control, social problems caused or exacerbated by use of the substance, risky substance use, and physical dependence. Now, to meet criteria for a substance use disorder, a person needs to have at least 2 of these 11 criteria occurring together. We can characterize them, or rather, for diagnosis, people with 2 to 3 criteria are considered to have mild substance use disorder, 4 to 5 moderate, and 6 or more severe. Now, you may be wondering about addiction and how that fits into this. Addiction is not a diagnostic term under DSM-5, but there is a Society of Addiction Medicine, and that American Society of Addiction Medicine defines addiction, as you see here, a treatable chronic medical disease involving complex interactions among brain circuits, genetics, and the environment, and in individuals' life experiences. So we often will operationalize addiction as severe or sometimes moderate to severe substance use disorder. So how common is substance use and substance use disorder? Every year, the Substance Abuse and Mental Health Services Administration conducts a survey of a nationally representative sample of US adolescents and adults called the National Survey on Drug Use and Health, which we affectionately call NSDUH. This is how we do public health surveillance of substance use disorder, and mental illness. So much of the data that I'm going to show you in the presentation come from this survey. So as I said before, and it's obvious, substance use disorder is conditioned on using the substance, so we'll start there. According to findings from the 2022 survey, NISDA survey, about half of adolescents and adults drank alcohol in the 30 days prior to the interview. Of those, about 45% engaged in binge drinking, defined here as 4 or more drinks for women and 5 or more drinks for men per occasion. So that 45% translates to about 20% of the US population. A little more than a quarter of people who engaged in binge drinking in the past month did so on 5 or more days, which meets the definition of heavy alcohol use. And that's 5% of people in the US age 12 or older who are estimated to be heavy drinkers. Alcohol use differs by age. So it's in terms of binge drinking and heavy alcohol use, the highest prevalence is in people who are 18 to 25, a period known as emerging adulthood. Now, NISDA measures or uses a past year time frame in measuring the use or assessing the use of drugs other than alcohol. And they do this, by the way, by asking people whether they used particular substances. So again, in 2022, they estimate that 25% of US adolescents and adults had engaged in non-medical use of substances over the past year. A little more than a fifth of people use cannabis, otherwise called marijuana, and that's 88% of people who use any drugs. So most people who use drugs use cannabis. And 35% of people who have used any drug have used something other than cannabis. And like with binge drinking and heavy alcohol use, it's most common among people who are age 18 to 25. It's 41% of people have used any illicit drug in the past year. Moving on to substance use disorders, around 10% had an alcohol use disorder. A little less than 10% had a drug use disorder in the past year, and 17% had any substance use disorder. Estimates for lifetime substance use disorders from another study, the National Epidemiologic Study of Alcohol and Related Conditions, showed that 30% of people had a substance use disorder at some point during their lifetimes. Sorry, that's alcohol use disorder, and 10% had a drug use disorder. And it's more common among people who are age 18 to 25. Substance use disorders, that's not surprising because substance use disorders tend to onset in the early to mid 20s. Rates of substance use disorder are also more common among men than women. Substance use, too, is more common among men than women, although the gap has been steadily closing. So even though women are less likely to use substances than men due to various biological differences, for example, differences in metabolism and brain structure, women who do use substances may be more likely to develop a substance use disorder than men. So this is a good place to segue into risk factors for substance use disorder. In public health and social work, we consider factors that influence health at multiple levels, from the individual level to societal factors. And we also think about how factors at all these levels interact with one another. So starting with individual risk factors, like most chronic health conditions, substance use disorders are caused by a complex combination of genetic and environmental factors. At the population level, 50 to 70% of risk for substance use disorders is attributable to genetic factors, which is a concept that's known as heritability. Importantly, this doesn't mean that in any individual, 70% of the reason why they have a substance use disorder is because of genetics and 30% is because of environment. This is a population level statistic, and it may vary in individuals. The heritability varies depending on the substance. So the evidence suggests that the majority of genes influencing substance use disorder are the same across substances. And then there are a few, there's some of the heritability that is attributable to individual substances. So as I've implied here, there are lots of genes influencing substance use disorder. And we're not talking about a single gene or even a few genes. So there's no gene for substance use disorder. And we know that there are lots, and we also know that we haven't identified nearly all of them yet. And there are lots of other risk factors for substance use disorder, and I'm going to highlight some of them here. It's also been found that children of parents with substance use disorder are at higher risk for a substance use disorder themselves, even after accounting for genetic risk. Having people in the family with a substance use disorder is one of the adverse childhood experiences, and other adverse childhood experiences, such as childhood physical and sexual abuse, are also risk factors for substance use disorder. Pre-existing mental health issues, such as ADHD, early onset depression, conduct disorder, those are risk factors for substance use disorder. And make it or associated with a higher likelihood of using substances and developing a substance use disorder. Difficulties in emotion regulation and personality traits like impulsivity and novelty seeking are risk factors and related to other risk factors such as early substance use and exposure to substances due to peer use. So in addition, permissive parental attitudes towards substance use are risk factors. And household poverty, neighborhood poverty or violence, limited access to education and employment, and stigma and discrimination. So here we have risk factors across all of those levels of the ecological framework, from individual to the larger social environment. Now, we also have lots of factors that have been shown to reduce the risk of substance use disorder. And these risk and protective factors suggest places where we can intervene. So some protective factors are social emotional learning skills, such as emotion regulation skills, decision-making skills, and interpersonal skills. Parental and peer disapproval of substance use and associating with peers who don't use substances, connectedness in schools, and positive family and community relationships. Also, parental monitoring and involvement. Now, as you'll note, you probably noticed those protective factors that I've listed tend to be things that occur at younger ages. And when we're thinking about primary prevention, which is strategies that aim to prevent risky substance use and substance use disorder before they start, by reducing risk factors and enhancing protective factors. We need to start early because substance use starts early. And some examples of primary prevention strategies are things like family-based interventions, such as parenting classes and home visitation programs, like Parents as Teachers, which started here in St. Louis. These aim to help caregivers access the resources and skills they need to build warm and supportive relationships with their children. School-based interventions that have been shown to make a difference are things like social and emotional learning programs. And they teach social emotional learning programs teach kids relationship skills, self-awareness, social awareness, emotion regulation skills, and responsible decision making. Community-based programs, such as Communities That Care, is one such program, and that engages community organizations and leaders to identify a community's risks and strengths, and then helps them select and implement evidence-based programs and policies for their community. So that's very important, is to involve the communities in designing interventions. And also policy interventions can serve as primary prevention. Taxes and regulation of substance use can help prevent or delay the age of onset of initiation of substance use. So we can't talk about substance use disorder and prevention of substance use disorder without talking about stigma. Substance use and substance use disorders are very highly stigmatized. Drug addiction is the most highly stigmatized health condition worldwide. Alcohol addiction is fourth. So what is stigma? A negative social attitude attached to a characteristic of an individual that may be regarded as a mental, physical, or social deficiency. That is the definition from the APA Dictionary of Psychology. Now, there are lots of different forms of stigma, and we are going to talk briefly about these three here with respect to substance use disorders. Public stigma is endorsement of prejudice and discrimination by the general public, in this case against people with substance use disorder, as well as perceptions among people in the general public that cast people as substance use disorder as socially undesirable. So the data on this and the next slide come from Shatterproof, which is an organization that conducted a nationally representative survey of addiction stigma in 2021. They asked participants questions about people with active substance use disorders, as well as people who are in recovery from substance use disorder. And as you can see, a little more than half of respondents thought it was likely that a person's substance use disorder was caused by bad character or lack of moral strength. And this made little difference whether or not the person described was described as actively using substances or in recovery. Which indicates that about half of people think that a substance use disorder is a person's fault. 58% said they were willing to have or unwilling to have a person currently using substances as a close personal friend, and a whopping 78% said they were unwilling to have them marry into the family. And these percentages are high even if a person is in recovery. 34% said they'd be willing to have them as a close personal friend, and 52% be willing to have them marry into the family. They asked us a lot of different questions about other things, and the results are similar. Would you be willing to have a person as a coworker, as a boss, etc.? All of these are examples of public stigma. It's important also to consider that stigma intersects. So the stigma of substance use disorder intersects with stigma against other groups. An example of this is racialized drug stigma, which comes from, is associating drug use with people of color. So this is due in part by purposeful propaganda campaigns associating drug use with people of color, and starting over 100 years ago. Henry Anslinger, who was the founding commissioner of the Federal Bureau of Narcotics, which is now the DEA, was a key architect of some of these campaigns, and you can see some very horrifying quotes here from him. And if we fast forward to the war on drugs, where the stigma, intersectional racialized drug stigma, is operationalized here, in the war on drugs, which criminalized drug use and possession in such a way that people of color are much more severely affected than white people. According to a 2013 ACLU report, African Americans were 3.7, so almost 4 times more likely than whites to be apprehended, despite nearly identical usage rates. So just to show you some data on that, if we disaggregate the prevalence of substance use, in this case, non-medical substance use, by, so this is not alcohol. So we disaggregate by race. We see that the highest prevalence is among non-Hispanic multiracial people. And if we look at these bars here, we can see whether differences are statistically significant. If they overlap, then there is not a statistically significant difference. This is kind of a quick and dirty trick. That's not right. It's not a trick. But it shows us, gives us some idea, but it's, I have to say with my epidemiologic hat on, that it's not a substitute for a statistical test. However, we can see that people who are non-Hispanic Asian Americans have lower rates of drug use disorder, and that they're roughly similar rates between Black, white, and Hispanic Americans. So if we're looking at substance use disorder, we also see little differences between Black, white, and Hispanic Americans, and lower rates among Asian Americans. This is just for past year substance use disorder. In the National Study of Alcohol and Related Conditions, they assessed lifetime substance use disorder and found that Asian, Black, and Hispanic or Latino Americans were all less likely to have substance use disorder compared to white Americans. So the war on drugs is an example of structural stigma, which are rules, policies, and regulations in society that discriminate against people with substance use disorder. A few other examples include denial of housing or services for people who use drugs or have a history of substance use. Another example could be the AADA, American with Disabilities Act, only protects people who are in recovery, but not those with active substance use disorder. And then the separation of substance use disorder treatment from treatment of other mental health issues, which happens both in terms of services and insurance coverage. This is very important because almost half of people with substance use disorder have mental illness. And almost a quarter of people with substance use disorder have serious mental illness. So we need to, when we have treatment of mental illness and substance use disorder separated, that means that people are, it's more difficult for people to get the care that they need. So the third type of stigma I wanted to talk about is self-stigma, which is internalized negative attitudes that are held by people with substance use disorder about themselves for having a substance use disorder. So by internalize, it's internalizing the structural and public stigma. And this can result in what's called label avoidance. So it goes that if people with substance use disorders are defective, and then if I have a substance use disorder, that means there's something wrong with me, therefore I don't have a substance use disorder. And the impact of all this stigma is that it keeps people from admitting that they have a problem and from getting help. It makes it more difficult for them to get help. And all of that means that if and when people do seek help from their problem, from their substance use, they might run into, so it makes the problem worse. And if and when people do seek help for their problem, they might run into more stigma from healthcare providers. And that's associated with inadequate and substandard care. So all of this means more substance use disorder and more severe substance use disorder. And that's perhaps one of the reasons, stigma is perhaps one of the reasons why only 24% of people who needed treatment actually received it in the past year. There are myriad costs for substance use disorders. From an economic perspective, they cost a lot of money in terms of healthcare and lost productivity, cause legal issues, problems with employment, with social relationships, can be devastating to families. And they also cause numerous other health problems, from liver disease to accidents to death. Substance use disorders accounted for 6.6% of the total disease burden in the US in 2019. So it's here number 4, the fourth leading cause of disease burden in the United States. Now, in the news a lot over the past few years have been deaths of despair, which are deaths due to alcohol and drug overdoses, as well as deaths by suicide, which we should note are often involve substance use. Drug overdoses in particular have driven this precipitous rise in death despair that we see here. And this intersects with other factors such as race and ethnicity. So while rates are increasing overall, they're increasing more precipitously, in particular for Black and Native men. Not shown here is that there are also differences by socioeconomic status, with more deaths among people with lower education and income levels. For example, and we can see here that rates of overdose are highest in areas with highest income inequality, and that the difference here between the rates in areas, this is counties with the lowest income inequality versus the highest income inequality, the difference is greatest for Black and Hispanic Americans. It's kind of dim here, but you can see that there's a 2.4 times difference here between the lowest and the highest rates of overdose deaths. So what can we do? This brings us again back to prevention. We think about secondary prevention, which aims to identify people at early stages of progression. And do this such as through screening and referral to services. We also think about tertiary prevention, which is interventions that minimize the negative impact of a health condition. So we need policy changes to provide equitable health insurance coverage for mental and behavioral health treatment. As an example of policy changes, policy also figures greatly into harm reduction. So let's talk briefly about harm reduction. Harm reduction is grounded in justice and human rights and focuses on positive change and working with people without judgment, coercion, discrimination, or requiring the people stop using drugs as a precondition of support. And I kind of think of it as the kind of like the opposite of the tough love approach. So examples are things like syringe access, and naloxone for overdose prevention, or for prevention of drug overdose deaths. Housing first, to talk about, is allowing people to have housing that's not preconditioned on their not using substances. So principles of harm reduction, a commitment to evidence, respecting the rights of people who use drugs, and collaborating with people who use drugs. So if we think about, as I mentioned before, working with the people who are affected by our interventions. And the last is avoidance of stigma. So when we add to that list for secondary and tertiary prevention, reducing stigma. So what works and what maybe does or doesn't work with stigma. Is this. So the chronic relapsing brain disease. So characterizing addiction as a chronic relapsing brain disease may or may not work. And it may help with self-stigma. It doesn't necessarily help in terms of public stigma. And here in this example here, which I think is implying that it's a chronic relapsing brain disease, and is tackling the stigma of addiction through education. Education is another thing that may or may not work. It does work if it challenges inaccurate stereotypes. But education alone is often not enough. So another thing that does work is avoiding stigmatizing language, which I've been trying to avoid here. So the National Institute on Drug Abuse, which in itself, it has a name that involves a stigmatizing language. They have this program, you can get continuing education credits for it. It's called Words Matter, and to teach people about non-stigmatizing language. So it says, instead of using these words, use a different term. So in particular, we want to use person first language, which means it's a person with X, in this case, a substance use disorder, a person who uses substances, and not an addict, alcoholic, drunk. I do want to point out here that misuse is considered by many to also be a stigmatizing term. This language also, the preferred terms are evolving. So this shows results from a study that has the differences in perceptions of people when a person is referred to as a substance abuser versus a person with a substance use disorder. So the study found that when someone was described as a substance abuser, people thought they were less likely to benefit from treatment and more likely to benefit from punishment. Also more likely to be socially threatening, so violent. People were also more likely to blame the person for their substance issues and to think the person could control their substance use without help. These findings have been replicated in different populations, for example, in healthcare providers, and have been replicated over and over. So other things that have been shown to work are emphasizing solutions, emphasizing societal causes versus personal causes, social contact with people with lived experience, and in particular, people with lived experience who are in recovery, and narratives that humanize people with addiction. Just want to point out here, or rather to disclose here in terms of social contact, that if you don't already know someone with a substance use disorder or who is in recovery from a substance use disorder, I am one such person, and I disclose for this reason, to reduce stigma. So narratives that humanize people with addiction are showing that a person is more than their addiction. So this, which I think comes from is a Canadian stigma reduction campaign, shows images of various people with who use drugs and talks about their other roles. So this man, a hockey fan, a coworker, an uncle. And I'm going to stop there with Stop the Stigma and open it up for questions. Thank you, everyone.
Great. Thank you so much, Dr. Duncan. We do have, we've had quite a lot of just good discussion in the chat and questions for you. And so I'll try to get to as many of those as we can. We've got about a little over 10 minutes. We had a couple questions toward the beginning of your talk, specifically about the likelihood of women having a substance use disorder. One person asked, are they actually less likely to have a substance use disorder, or is it just because they are less likely to have been diagnosed or reported? And then someone else asked if, women are, when they do engage in substance use, is that likelihood influenced by men?
Okay. To answer the first question, so in epidemiology, our psychiatric epidemiology studies, we ask people about their symptoms, and then I showed you those 11 symptoms. And so we ask people, have they experienced those? Have they experienced them together in a 1-year period? And then we use a computer algorithm to add them up and see what percentage of people meet criteria for a substance use disorder. So we're not asking if they've been diagnosed. I mean, we may have another question about whether they've been diagnosed, but these rates are coming from asking people about their symptoms. And we don't tell them that we're asking about symptoms of a substance use disorder. So that maybe differences in diagnosis are not reflected there in our epidemiology. In terms of women's substance use being influenced by men, I actually don't know the answer to that question.
Yeah, that was an interesting question, and I would be curious if any work has been done around that. A comment really, but I think I have sort of a question about this too, of those intervention programs that you had mentioned. We had someone comment that many of them have come under fire recently. And so I don't know if you want to speak to that a little bit.
They've come under fire. And I'm just trying, can you, I guess, specify more of the question?
I'm curious about in what ways is it policy related that these programs have come under fire? Is that really it's kind of politically driven? Is that what I'm understanding?
That is my understanding too, that it's politically driven. I mean, I do also think it's a reflection of stigma. And thinking that both stigma and if this is related to stigma, but not feeling like these things are important.
That makes sense. Speaking of just the stigma that you kind of talked about, we did have a question if you know of any examples of St. Louis-based destigmatization destigmatization education efforts or programs, or any that you've been associated or that WashU has been associated with?
Okay, I noticed that there's some people from MIMH on here, and I'll bet that they would, that's Harm Reduction Central. And in terms of destigmatization, which is also part of harm reduction, they might be able to speak more to that. And there are lots of organizations. Let's see, this Liz says, stigma reduction training specific to first responder audiences. Perfect. In terms of what we're doing at WashU, well, we did do a survey recently. We're analyzing the data from that to do about the extent of the problem, or the extent of stigma among our students here at the Brown School. And then from there, we're going to look at interventions, and my colleague Phil Murata and I are interested in reducing stigma, and in particular in our future social work and public health practitioners.
Thank you. Here's a good question about how can we make programs like this culturally relevant and accessible, both logistically and in terms of application?
Culturally relevant from a global perspective.
There wasn't
Or
really a
is it-
specification.
Yeah.
So yeah, I would think global, but also, you know, culturally across race and that sort of those distinctions as well.
I think that to do that, we can't like descend from our ivory tower. And it needs to come from the, I don't want to say bottom, but from the roots up. And so we can work with people in different cultural environments to find out what they need.
Looking through the questions here, a lot of really great, just kind of back and forth discussion about the war on drugs and the racial motivation for that, drugs being, you know, highly criminalized specifically in practice toward Black, Indigenous, and people of color more so than toward white individuals. There was a question, you know, African Americans endure many disparities in America, disparities of health, housing, income, and justice. These are hate crimes, but also diluted as racism. Questions. There was a question about, you know, why African Americans are arrested more for I'm assuming for drug-related instances. I don't know if you have any information about that, but
well, racism and so at every step of the way, in terms of, you know, African Americans more likely to be pulled over, and if you condition on that, more likely to be searched, and if you condition on that, more likely to be arrested, and on up. But the bias is not always explicit. I mean, I also know that people don't always, I mean, like judges don't realize that they're sentencing more harshly people of color versus white people. So I don't know. This is, I'm like, this is a huge issue. I recommend to everyone, if you haven't read I'm looking at the book because I forgot the name. Michelle Alexander's book, The New Jim Crow, which talks a lot about the war on drugs. Yes.
Read that one as well. That's a good recommendation. See, here's a good question. What do you think is the difference between addiction and substance use disorder? Also, what do you think are some of the drawbacks of looking at the issue as a disorder / support the disease model of addiction?
That's a good question. So, I mean, it's just words, I guess. So in terms of like mild, moderate, and severe substance use disorder, and is mild substance use disorder addiction. And what we do know is, well, a bunch of things, but that in terms of the course, and whether people are able to resume use, like remit and still use, all that is, people with mild substance use disorder are less likely to be able to use non-problematically. More likely to than people with moderate or severe substance use disorder. But I just realized that people use different terms, but I think they're all kind of getting at the same construct. So what was the second part of the question?
And then the second part was, I'm guessing if they're wondering if you support the disease model of addiction.
Oh, the disease model. So I read a thing recently and about the disease model, and that, people, it's one of those things that I think most people, us who study addiction, subscribe to the disease model, and that whether or not that is true is a question of whether or not it's useful. So in terms of reducing stigma, so we used to think that if, and this is the case for other mental illness, so that if we tell people that it's a disease, if it is, and we treat it like any other disease, that will reduce stigma, but that hasn't necessarily been shown to be the case. So this thing, I've read several articles recently making that argument that it's maybe not for public health the best thing, but is it a disease? I think as much as, and another thing I read recently is that a disease is what people say it is. So, it's also a latent construct. A disease is a latent construct.
That's really helpful. Thank you. I know we are getting close to time, and there are many questions that we weren't able to get to, but I do really appreciate just the very active involvement in the chat and the questions that you all submitted. I will hand it to Sarah Sims to close us out. Thank you so much, Alexis, for your insights and for joining us today.
Yeah, thank you, Sarah Lucan, and thank you, Dr. Duncan, and thank you everybody again for watching. I put a long note in the chat with several links. I did put the link to Michelle Alexander's book in there that Dr. Duncan referenced. I also put a link in there where you can watch a recording of today's program, as well as any of our past programs. We have over 200 programs recorded and shared on our website. You can also access that with the code there. I would also love to invite you all to join us later this week, just in a couple days. On Thursday, we have another program this one, sorry, it's on the screen. It's entitled Sex Chatting, Tools for Expanding Sexual Self-Efficacy and Teaching Sex Education. Again, this is a free webinar. And so there's a link to register for that in the chat as well. And then finally, I want to send a special invite to all of you to our Black History Month programming, which will be, of course, in February. We have 5 free webinar programs in the month of February celebrating the art of activism. You can kind of see a preview of that on your screen. And I invite you to check out our Black History Month website, which I put in the chat as well. So with that, again, I just want to thank everybody for coming today, and especially thank those who commented and asked questions and were so engaged in the chat. Thank you, and we will see you for the next Open Classroom. Goodbye, everybody.